Hi there. My name is Anna Shah. I am a neurologist at the Rocky Mountain MS Center at the University of Colorado. Today, we're going to delve into another portion of learning about MS for primary care doctors. We're going to look at disease-modifying therapy as well as comorbidity management. Let me go ahead and share my screen. So we'll do a bird's eye view of disease-modifying therapy without going into the weeds about this. When we look at MS, well, gosh, it is impressive how far we have come from where we started with our first MS treatment in 1994. And the nice part with MS is these treatments just keep coming. In the bottom right-hand corner, you'll see there's about a couple more on the docket that we haven't put, but ublituximab, depending on when you're watching this, is slated to be approved or go up for FDA approval in December of this year of 2022. When we look at MS medications, they are certainly not all made the same in terms of how effective they are and how safe they are. And this is not something I would expect primary care doctors to initiate or manage. But I think this becomes important when we're thinking about what are the risks of some of these treatments and what are the benefits that we gain with some of these treatments. In this slide, I'm trying to illustrate a little bit of a difference in treatment paradigms that are sometimes used in MS. So what you'll see with that very back chart, the green one, if you're looking at the course of time with disability being on your y-axis, what you'll see is natural disease course shows a slow accumulated progression or the slow accumulated onset of disability. When we think about when and where to start patients on treatment, I think the difference in the blue versus the red really shows us why we should practice early therapy as much as possible. The earlier we get patients on treatments that shut down inflammation, the less neurodegeneration patients have, and hopefully that translates into less disability. If we wait and delay therapy until patients are accumulating more disability, while we might also shut off effective new neuroinflammation, unfortunately, we don't have a way to reverse damage that has already been done. I'm going to show you a couple of different treatment approaches here. So under the letter C, you'll see this treatment approach called escalation therapy. And what this means is when we think about MS treatments, if we separate them into three different groups based on form of administration, with injections being class 1, oral treatments being class 2, and infusion treatments being class 3, one of the ways that we used to practice fairly often was this escalation approach, which is I'm going to start someone off on a treatment in class 1 or class 2. And if they demonstrate that they're having new inflammatory activity, whether that's a clinical relapse or new MRI activity, I'm going to escalate them up to the next category of medications. If you look in the background of that image on C, the black lines, that really does a nice job of showing us what is the probability of new inflammatory disease activity, again, can be either clinical or radiographic. What is the probability of that happening as they age? And you can see a really nice inverse relationship. So when you look at how escalation works, it doesn't necessarily quite make sense with how disease activity is going. If you look over at the image labeled D, this is showing us highly effective immunotherapy early, saying we're going to start everyone off on something in that class 3. But now you can also see, while that is really effective, especially at the onset of disease activity, do we eventually reach a point where we don't necessarily need that? There are also medications under this image that is labeled as E, which is induction or maintenance therapy, where you give them a really strong effective medicine and then you redose as needed. But probably the best idea, or in an ideal world, would be to practice what image F shows us, which is de-escalation, which is start people off on a strong medicine and at some point in time de-escalate the strength of that medicine and potentially the immunosuppressive component of that medicine to kind of match where they are in terms of disease activity. Let's talk a little bit on the other side about comorbidity management. And this becomes incredibly important because this is where primary care doctors have a huge role in this. So when we think about care models for long-term management of MS, we know that it's not necessarily one individual, one subspecialty that's working on its own. It's really primary care working in conjunction with their neurologist or MS center, also working in conjunction with the subspecialists that patients need. And this can involve individuals in the rehab realm, like physical therapists, occupational therapists, speech therapists. It can involve urologists, urogynecologists, psychiatrists, physiatrists. So there's a lot of different people involved in the care model for long-term management of MS. And one of the things that becomes incredibly important is how we all work together. So in general, we have MS centers that see these patients, and then the patients might even have local or general neurologists. And then of course, there's primary care and subspecialists. And this becomes important because it's always important for primary care doctors to know that we're all working together as a team. And sometimes they might be that primary point or that quarterback, but everyone works together as a team. Now, this is one of the things that I think is most important to think about from a primary care standpoint with MS, and probably something that we as MS neurologists don't emphasize as much as we should. There has been several studies published looking at the association of poorly controlled vascular disease being associated with more rapid disability accumulation. And now it's hard to know if these are correlational or causational, but we do know that good aggressive management of their vascular comorbidities, things like high blood pressure, high cholesterol, diabetes, tobacco use are going to become incredibly important in making sure that we're allowing our patients to do what they want for as long as they want to do it in whatever manner they want to do it. Now, in a study of about 23,000 Canadian MS patients and looking at over 100,000 matched controls, they found that MS patients had a higher frequency of all comorbid illnesses except dyslipidemia at diagnosis. And the most common comorbidity was really depression, with it being almost 1 in every 5 patients. And number 2, not trailing too far behind, was hypertension. Now we see this a lot more prevalent in our male patients with MS, and these are things that are important for us to keep an eye on. MS participants had a 17% higher odds to have diabetes and 30% higher odds for ischemic heart disease than their matched controls. The other comorbidity that I bring up that's a little bit different from vascular comorbidities is really looking at infections and medication side effects. Now, when we see patients that are worsening, we talked about recrudescence in one of the other topics. We know that not all worsening that MS patients have are necessarily just from MS. Primary care doctors become incredibly important in helping us identify high-risk infections when we think about brain infections like progressive multifocal leukoencephalopathy, or probably on the other end of the things, more common infections like urinary tract infections. We bring up this idea of PML, or progressive multifocal leukoencephalopathy, because almost all MS drugs have some risk for this infection. Urinary tract infections are quite common in MS, and it is very important to pay attention to these because these often occur without typical urinary symptoms. What I mean by that is a large percentage of our patients have urinary urgency. And so it is not as helpful to assess if someone is having a urinary tract infection by just looking at urinary urgency. There is also a high prevalence of saddle anesthesia or perineal anesthesia. So most patients may not feel burning with urination. Some of these MS medications, particularly thinking about some of the infusions, may increase the risk of urinary tract infections too. So always important to keep an eye out for those. And we also talk about this idea of immunosenescence. What immunosenescence is this general waning of immunity as we get older. We think this comes into play around the age of 50 to 55. So of course, if we've got MS patients that are on immunosuppressants, in combination with immunosenescence, we might see higher risk of infection. Now, where does this all come to a head? I think as a whole, we all want to work together to improve the social determinants of health in our patients. And as you can see, the social determinants of health listed there on the right, we know that there are socioeconomic, racial, and ethnic biases within our healthcare system that affect access. And there is really limited diversity in our clinical trial